Hi, good evening. My name is Dr. Firas. I'm an interventional cardiology and structural heart specialist. I'm the chief of the Heart Center at the American Hospital of Dubai. I want to first thank the organizers for inviting me for this prestigious meeting. And I want to just dive into the talk. And I happen to have, fortunately or unfortunately, the last talk of the night. So I will promise you will make it very brief. So the title of my talk is The Role of Minimal Invasive Therapies in the Stroke Prevention Among Patients with Atrial Fibrillation. The Watchman device, which is a left atrial appendage closure device. My financial disclosures, I'm a speaker for Boston Scientific. So we're going to try to address mainly one item on the agenda, but it's a pretty broad item, is that starts with a question: is there a need for a device-based therapy alternative for stroke risk reduction in patients with atrial fibrillation? Now, I hope by the end of the presentation, I can convince you all that the answer to this question is yes. We're going to try to accomplish that answer by talking about some device specifics, talking about clinical trials, efficacy from a stroke reduction and bleeding reduction, and then procedural success and safety. And then hopefully we dive into some future patient populations. So let me start with one of my cases. I did this approximately about 18 months ago. This was my last patient in the state. This was a 76-year-old man who has chronic atrial fibrillation and has recurrent episodes of GI bleed, requiring multiple transfusions. And his history goes consistent with severe aortic stenosis. He actually had a prior TAVR, CHF with a heart failure with preserved ejection fraction, hypertension, diabetes, prior TIA, and the list goes on. And you can see by calculating his CHA2DS2-VASc score came out to be 8, and by calculating Hasbled score came out to be 7. So quite high CHA2DS2-VASc and high Hasbled scores. We'll come back to the case later. So is there a need for device therapy and an alternative for stroke reduction in patients with atrial fibrillation? The burden of atrial fibrillation, as you know, is growing. It's expected that the population of atrial fibrillation in the US to grow up to 5 million by 2050. We know that the risk of stroke with atrial fibrillation is 5 times more in those patients compared to their cohorts that do not have atrial fibrillation. We also know that about 1 in 5 strokes occur today are from atrial fibrillation. We're talking about worldwide, the prevalence of atrial fibrillation is 1.5 to 2%. And it is a staggering increasing number. About 18% of the population of age above 85 have atrial fibrillation. So you have all patients above 85 years old, 1 in 5 of them have AFib. Again, as earlier addressed, these patients have 5 times higher risk of stroke. And it's more important to point out that the cause of that these atrial fibrillation strokes tend to be very large in terms of disability, expectedly and rightfully so, because these clots are usually larger than a clot that may come from an internal carotid artery or even a stroke that happens from lacunar infarcts. It is expected that if you have 1 stroke from atrial fibrillation, you have a 1 in 5 chances of occurring again, so a very high recurrence rate. And as we know that the role of atrial fibrillation is very high in terms of developing heart failure. The mechanism of atrial fibrillation and stroke is well described. This occurs because of the stagnant flow that happens in the left atrial appendage, which then becomes the nidus for future clots. And these clots can dislodge from the left atrial appendage, travels through the arterial system, and cause strokes. It has been reported that 90% of strokes in atrial fibrillation come from the left atrial appendage, and the other 10% come from other sources or other locations. And this is one of them. We've all seen these. This is a large clot, as you can see, lingering in the left atrial appendage, waiting to dislodge. Stasis, as we know, is the risk factor. And as reported, 90% of these strokes in these patients linger in the left atrium. So what does our guidelines tell us? Well, we know that all these patients should have now in the class 1 indication their CHA2DS2-VASc score calculated, whether it's European or Northern American ACC guidelines. And they also should have an Hasbled score with a 2A indication. And the question and the challenge and the clinical responsibility that we all have to those patients is to balance their stroke prevention and their bleeding risk. The CHA2DS2-VASc score is reported here. I wanted to point out that obviously the higher the score, the higher the risk, but it's also important to point out that these risks, whether it's 1.3%, 2.2%, and the list goes on, is actually an annual risk. And so when you're talking about risk of stroke of 1.3 or 2.2 for a CHA2DS2-VASc score patient of 2, this is per year. So the next year is 4.4, and the following year is 6.6, and the list goes on. You'll be surprised about how many of our colleagues, either cardiology, non-cardiology, or even some cardiologists, that they would say, well, what's the point of the Watchman device if my patient's risk is only 2.2? Well, it's an annual risk, not a cumulative risk. And we try, as we strive to improve the risk of stroke lifelong, not just for 1 year. Hasbled score is also a calculation that needs to be done in all these patients. Again, this is a score that determines their risk of bleeding. And again, same thing, their risk of bleeding goes up as their Hasbled score goes up. And this is, again, an annual risk. And in this graph, you can see that in the red, this is their annual risk, but see how much a cumulative risk adds up as they go into a 10-year risk for the same Hasbled score. So when we calculate the CHA2DS2-VASc score, we give them a number, and if that number is 0, the recommendation is no anticoagulation, i.e. anticoagulation can be omitted. If the score is 1 in males or 2 in females, then it's reasonable to recommend, it's reasonable to start anticoagulation, but it's not necessarily recommended. But once the CHA2DS2-VASc score is 2 or more in male or 3 or more in female, you have to start them on anticoagulation. Now, in reality, that doesn't happen. And you can see here, this is a analysis that was published just reflecting the real world use of anticoagulation. And you can see in the dark blue, and then in the brown represents the patient population that are taking either warfarin or NOACs, novel anticoagulant. And across the different CHA2DS2-VASc score guides numbers, you can see that the number doesn't even get better than 50%. And there's many reasons for lack of compliance or not achieving at least 100% or close to 100%, many of which are listed here, either relates to bleeding or relates to interaction or just a fear of taking blood thinners. The data for the NOACs is no different than it is for warfarin. This is a published data that shows that even when you start them, 100% of them, they start early on. Within 2 years, you can see their compliance rate or their drop-off rate goes to 30% less in the NOACs and 40 to 50% in the warfarin. And if you look at the trials, these are the pivotal trials for all these NOACs. These patients have been followed, as we all know, in these trials and in phone calls, yet still their drop rate and discontinuation rate is quite high. The reason being is one of this is what we see here. These are catastrophic bleeding events that we can see here on the left is a bleeding, a hemorrhagic stroke or a hemorrhagic transformation of an ischemic stroke. Fortunately, these are very rare, but they are very devastating outcomes. And this is, unfortunately, sometimes the price that some of our patients have to pay with the use of anticoagulations. So the Watchman device is the most studied device for left atrial appendage closure. It's the only one proven to have long-term data from randomized trials in multi-centers, 5 studies, and actually even more today of more than 2,400 patients, nearly 9,000 patients per year. The Watchman is a safe alternative to long-term warfarin, which offers comparable stroke risk reduction and enables the patients to stop taking the warfarin. I can't tell you how happy these patients are when you tell them on the day number 45 when you do their TEs that you no longer need to take the blood thinners. The Watchman therapy have been demonstrated to show comparable stroke risk reduction statistically, and also statistically superior reduction for major non-procedure related bleedings and cardiovascular death compared to warfarin. So let's talk about some specifics to the device. The left, I want to just spend 1 minute or so on talking about the left atrial appendage. The left atrial appendage actually develops in the 4th week of embryonic life, and it actually acts as the left atrium for the fetus. I've learned to know that these appendages are different, just like your thumbprint. Every patient, every person has a different appendage, and now we're giving them all kinds of names. And you can see that still a good portion of appendages that have not been given names. But basically, the morphological characteristics of these appendages are different. We never pay attention to this until you start living in the appendage and deploying devices. These morphological derangements actually play a role. Of course, when you prepare your patients for a Watchman, they have to have a thorough transesophageal echo. They have to measure these angled appendages, angles 0, 45, and 90, and 135, and these angles come to play when you deploy the device intraprocedurally as well. As the Watchman device has a delivery catheter, so we get into the venous axis. This is a venous procedure. There's no need for getting any arterial access. And when you get in, you put in a 14 French. I usually put a 16 French, and then especially to patient has a large pannus, and then through the 16 French, you can deliver your 14 French catheter. Prior to that, of course, we'll use whatever technique you're comfortable with in your transeptal, either the Brockenborough or the other options. You get your transeptal technique, which is a very meticulous procedure. This could make or break your case. And sometimes if you don't like your transeptal puncture, you come out and do another one. And you have to be in that posterior inferior zone of the fossa to give you coaxial access to the left atrial appendage. And once you're in the left atrium, then you deliver your catheters into the appendage, and then you deliver your Watchman. I usually tell my patients this is a minimally invasive procedure. It's a permanent implant. It's not going to come out. It usually takes about 24-hour stay in the hospital, and the procedure itself is a 60-minute procedure, give or take. This is the older version, or the current version. Now we're moving into the newer version. This is the first version of the Watchman device. As you can see, the design, we're not going to indulge too much into the details about this in the talk. And this is the new version, which is the Watchman Flex. And I've just talked to one of the experts in the Watchman and was told that 55,000 hours of engineering time has been put to move from this device to this device. And it's a very novel technique and a very novel product. You can see that the device itself is shorter now, and there's extra struts built within the device to give it higher compressibility. And the shorter feature and the higher compressibility feature relative to the first version allows a larger access of larger appendages, larger numbers of appendages, where some cannot be done with the original version. And also there's 2 layers of J-shaped anchors that gives it a better anchor, and also gives it the ability to retract and redeploy, and not having to and fully recapture and use the same device multiple times, even when you fully recapture. So the procedure does take about an hour, give or take. It's a cath lab. You don't need an OR. Usually it's discussed in the heart team, interventional cardiologist, or an electrophysiologist. This is a procedure that can be done by both skilled physicians in the heart team discussion, and also intraprocedurally. A non-invasive cardiologist plays a major role in the discussion, and also in the transesophageal echo. And then, of course, cardiac anesthesia. T is done under general anesthesia. You can use this under conscious sedation. Some operators are now moving away from general anesthesia, and it's a venous transfemoral access. Before we deploy the device, a lot of discussions happen in the chit-chat that happens regarding the pass criteria. This is a criteria that has to be established before you release the device. You cannot release the device if it doesn't pass the pass criteria. In fact, when I said about an hour takes of the time the procedure takes, you can get the venous access in 5 minutes, get the transeptal in about maybe 10 minutes, deploy the device in about 10, 15. And literally the last half an hour, we're just sitting, talking to each other, and going through each and every one of these criteria to see if the device is stable and can be released. So the P stands for position, and this is where you do the 4 angles of the TE, and you look at basically how much of the relationship between the shoulder of the device and the ostium of the appendage. It's expected, or it's accepted, I should say, to have about 10 to 12 millimeter shoulder, which is, or just a simple rule of thumb, half of the length of the device. More than that, the device did not pass the P criteria of the pass, then has to be retrieved. The second letter is the A for anchoring. This is what we call the tug test. This is where you really need to pull on the device and see the device come towards you and then go back, and kind of almost like a pinball technique. And that's a test that also needs to be done probably multiple times, and also allows the device to lodge itself. And if it moves or it comes out, and then that may be grounds to removing the device and going with another device. The S for size, and that's where we calculate the compression. Again, we go through the 4 angles, and we deploy and we measure the width of the face of the device, and it has to be within the 8 to 20% compressibility percentage of the original size of the device. So for example, this device is a 24 millimeter device. The measurements of the shoulder comes out to be 20.8. We know that 20% compressibility is 19.2 and 8% compressibility is 22.1. So anywhere between those two numbers is acceptable, and the 20 comes out to be 18%. So this is an acceptable compressibility. And finally, the S for the seal, and this is where you look for any color flow around the face of the device. Anything less than 3 to 5 millimeter is acceptable. Anything more than 5 millimeter is grounds to remove the device and use a larger device. Won't spend too much time on this, but this is we get to the device, we get to the septum, and then we position the sheath into the. Now you use your pigtail to navigate through the septum. And then it's a soft edge, usually a 5 French. You inject, you do a left atrial appendagegram, and then you've now sized the appendage angiographically, in addition to your pre-procedure sizing by TEE. The device comes in, the delivery sheath is 12 French, but the access sheath is 14. And it's really a pin and pull, and you really sometimes have to lean a little bit forward, but not push. And that's how you deploy the device. You do the tug test, and if you like it, passes the pass criteria, you do a final angiogram, and the release is very simple. It's a counterclock rotation of the knob, 5 turns, and the device is gone. This is how it looks like on the TE, and you can also, if your lab is equipped with 3D TE, you can see how beautiful it is on the 3D as well. This is a canine model. You can see after 45 days, it endothelializes nicely, and this is the beauty about the catheter and the fabric sheet that goes over it. And here you can see this is a human pathology if somebody passed away 9 months post-implant, and it was not device related, but they managed to get the tissue of the heart. So what happened to our patient here? Again, you can see that we got access to the septum, use the appendage pigtail technique, do your appendagegram, and then here you see the device deployed, do your angiogram again when the device is in place, and then we do a tug test. You can see me here pulling on the device, and the actual Watchman device is moving with the heart, but it's not coming out from the appendage. This is a secure position. Finally, we just do our final angiogram and see the nice flush between the surface of the device and the mitral valve plane. We're going to go quickly about some of the data. This is the timeline of the appendage. This is the CE mark was 2009, and then FDA mark was 2015. There were 2 randomized trials and 3 registries, and there's even a fourth registry also published that pertains to the newer device called the Pinnacle. But the data is pretty strong. Starts with the 2 randomized trials, 2-to-1 design against warfarin. You can see that their CHA2DS2-VASc score was quite high, and their Hasblad score was quite high. Here you'll see the forest plot curve. You compare the Watchman to the warfarin. You can see the efficacy of stroke is comparable. When you break it down to all strokes and ischemic strokes with systemic emboli versus hemorrhagic stroke, the hemorrhagic stroke was statistically significant in favor of the Watchman. There was a trend for a higher ischemic stroke early on, and I'm going to show some slides to that point. And this has to do with the early phase predominantly of the trial. There was about 5 events that happened in the Watchman device arm that of strokes. Actually 5 happened intraprocedurally and 1 happened prior to the procedure. But if you remove the 6 procedure related strokes, you can see that both events are comparable between the 2 arms. While clearly the intention to treat analysis by far is the most important, however, this analysis does actually show some insight into the mechanism of action of the appendage closure. It is consistent, as you can see, with the underlying hypothesis that local therapy with appendage closure achieves similar, almost numerically identical results as systemic anticoagulation. And here you can see when you remove these 5 events, you can see that the stroke events come almost equal. There was a difference in the disabling strokes in favor of the Watchman versus the warfarin. That's a very important observation from these meta-analyses that incorporated both, by the way, PROTECT and PREVAIL. And also you can see, and here you can see in the bar graph, that there was a substantial drop in the amount of disabling and fatal strokes. The non-disabling stroke almost came out to be the same, or maybe slightly more on the Watchman, but this difference is substantial. Watchman provided about a 55% relative risk reduction in the amount of disabling strokes compared to warfarin, which was statistically significant. There was also a favored outcomes in outcomes of cardiovascular and unexplained death favoring the Watchman, and you can see that was actually statistically significant. And of course, the major bleeding that are non-procedure related, and that's expected because these patients obviously are no longer on warfarin, and therefore their major bleeding risk are substantially lower on the Watchman arm. And if you plot all these trials, you can see that they are actually this is the projected outcomes of untreated AFib. This is the bolded line is the projected outcomes of patients treated with warfarin, and you can see the other trials of the Watchman, how they compare themselves to the Watchman. The bleeding risk is quite high. I'm sorry, I should say the bleeding benefit is quite high. Early on in the trial, they can see that the bolded line representing the Watchman and the dotted line represented the control arm, which is warfarin. There was a higher bleeding events in the first 7 days, most likely procedure related. But as you pass beyond the 7 days, you can see the warfarin arm has a more substantial bleeding events compared to the, this is a Kaplan-Meier curve freedom from bleeding events. And you can see that the Watchman showed a substantial 72% drop of relative risk reduction in the amount of bleeding compared to the warfarin. Is Watchman safe? This curve, these bar graph shows that it answers that question. Of course, complication events were reported differently in these trials, but it is on a broader term. You can compare these events, and you can see in the first half of beyond the first half of the PROTECT trial, the event rates dropped significantly, and it was comparable to any left atrial appendage procedure, such as left atrial or left atrium ablation. And as you move on, and event rates or complication rates to continue to improve. And this is especially important in the PREVAIL trial, where 50% of the operators were new operators, and the outcomes continue to improve. These are the breakdown of the outcomes, and you can see them as we move from the early PROTECT all the way down here to the evolution, which is the post-marketing. You can see there's a substantial drop in the event rates of complications. The predominant one, obviously, was the pericardial tamponade. But I quote my patients, the risk of the procedure is 1 to 2%, and closer actually to 1% than it is to 2%. The success rate, you can see it here across the different trials. You have a 95% success rate of deploying the device. Yes, there's a 5% chance of not being able to deploy the device, either because the appendage is too small or the appendage is too large, but that's really what you report to your patients as well. This is the post-procedural regimen. Again, this differs between the United States and the European Society. We in the States, we start these patients on warfarin and aspirin, and then at 45 days they do the TE imaging or CT scan, which I have moved a lot, and a lot of the operators have moved to just doing a CT scan, basically looking for device thrombus, and then or thrombus on the device. And if that 45 days shows that the face of the device is clean, that's the day that the patient will love you for. When you go and tell them you no longer need to use the anticoagulation. And trust me when I say this does make their day when you tell them that. And after beyond that, you continue the aspirin and Plavix to 6 months, and then beyond 6 months, you continue the aspirin either for 1 year or indefinitely if they have other risk for atherosclerosis. If, however, you find a thrombus, in rare events, about 1 to 2% been reported in the trial, at the 45-day cutoff on the TE, then you would have to extend the anticoagulation for 6 months and then re-image the TE. And most of these patients, after the 6 months mark, the thrombus would be resolved. The nice thing about this is that a lot of people, when you look at the evolution trial, that a lot of the operators ventured off with different modalities, and now we have really no one standard for post-procedure. You can actually use a 3-month DAP therapy post-procedure. You can use a 3-month NOAC post-procedure. You can use a 45-day NOAC, then DAP therapy for 3 months, and then you can use a 45-day vitamin K and DAP therapy for 3 months. All these methods have been validated by the wonderful evolution trial that showed that the outcomes are comparable. And so there is, as you all know, it's not a one size fits all. Not all your patients can get that 3 months or the 45-day warfarin. In fact, some of them cannot. Some of them have contraindication. And that led the operators and some of these registries to look outside the box and try something new. And sure enough, they actually have now adopted 4 different regimens. This is their discontinuation rate for Coumadin. Again, 92% in the trials at the 45 days and 12 months, 99%. So who's eligible for it? Anybody who has non-valvular AFib and a CHA2DS2-VASc score above 2 and is suitable for short term and has a rationale to come off the anticoagulation. This is the guidelines. The United States, this is the ACC guidelines. It's a 2B indication, and in Europe, it's a 2B indication if, of course, their CHA2DS2-VASc score is above 2, and they have a reason to come off the anticoagulation. The Munich guys formed this very nice document of who exactly are these patients, and I won't indulge too much to it, but I would urge you all to read about it because it does open up the issues with the trial. And so if you break down your patient population, 2% of the population have AFib, non-valvular AFib is about 70 to are not moderate or to severe MS because these people cannot come off the warfarin. The rest have a 64 to 88% with a CHA2DS2-VASc score 2, and these people can be broken into 3 categories. Those who have no issues have no problem with it, but those who have relative or absolute contraindication, those are the ones that should be eligible for the Watchman. As their role of DAP therapy, the ASAP1 has done it, and we are waiting for the ASAP2. So I want to summarize by saying that from a safety standpoint, Watchman has a 95% success rate. And from a primary efficacy standpoint, there's an 18% reduction in events, 55% reduction in disabling stroke, and 80% reduction in hemorrhagic stroke. Statistically, Watchman have shown significant improvement over warfarin in terms of mortality. So 27% reduction in all-cause mortality. This was statistically significant, and 41% reduction in cardiovascular unexplained. The Watchman statistically also showed significant improvement in major bleeding, expected because they don't take warfarin. And then the warfarin cessation rate was 92 to 99%. I won't talk too much about the clinical trial, but I would. This is a trial that was built to pave the road for the new version. I will stop here for the time, and thank you very much for your attention. I'm happy to take on any questions.
Thank you very much for this presentation, Dr. Alani. I think it's you covered it all. It's so impressive, and I think it's from this I don't think we'll have any question. All the questions that I kept in my mind, you really went through it nicely.
Thank you.
Thank you very much for the presentation. We appreciate your presence with us in this edition of GIS. I appreciate it.
Thank you very much. Thank you for having us. Have a wonderful evening.
You too. From this, we'll reach our conclusion for tonight. Thank you very much for all of you attending with us today. It has been a great day. We have a lot of good cases, left main, bifurcation, complication that have been solved with a unique strategy. We learn a lot from live transmissions and live in a box, renal denervation, great moderators, great panelists, and great discussion. And I think it's a great day and a great scientific day. Hopefully we met your expectation from our first day. We promise tomorrow we'll give you more scientific education materials. We'll start tomorrow a bit early. We'll start at 3 p.m. UAE time, 2 p.m. Saudi Arabia time. We'll start with live transmission from France with Dr. Anthony Lavon. And hopefully we can start early and finish early. We're going to have a lot of interesting cases, a live transmission, live in a box, and structural session with a mitral clip and TAVI and valve. So thank you very much for joining us. I wish it was a great day for you and expecting to see you all tomorrow. Have a good night.